everywhere we look at people talking about this topic only. You pick up the newspaper, you switch on the TV channels, you go to social media, everyone, most of the people are discussing about this topic somewhere or the other. So we, from Blue Circle, we thought that it would be worthwhile that we discuss this topic, but with subject expert. And so keeping this in mind, we invited Dr. Chandrakant Lahariya to educate us on various aspects of the third wave. Before I invite Dr. Chandrakant Lahariya, I would like to take this opportunity to introduce Mr. Atul Gupta from Blue Circle Medi Services Private Limited. He is founder and CEO of the company. He is an alumni from IIM Ahmedabad, a social entrepreneur who, prior to his current assignment, played a key role in the establishment of 3 other greenfield ventures. Mr. Gupta has been counted amongst the youngest CEOs of a leading MNC in India with extensive media profiling and coverage. Now, I would like to request Mr. Gupta to please take over from here.
Thank you very much, Monica, for the kind introduction. At the outset, I would like to welcome all our principals, teachers, and parents of all the esteemed schools who have joined in this webinar. Set up in 2011, Blue Circle Medi Services is a leading provider of managed healthcare services in India. We are going to be celebrating 10 years of our operation this year. Blue Circle Medi Services offers a comprehensive health, hygiene, and safety services, which is a trademark program to all its partners. The company has recently been recognized in Dubai, UAE as one of the top 50 global healthcare companies by Smart Health USA. I would now like to introduce Dr. Chandrakant Lahariya, for whom we are all here gathered together to hear. Dr. Chandrakant is a medical doctor, vaccines, public policy, and health systems expert. For 13 years, he has coordinated WHO's, the World Health Organization, work in India on new vaccines introduction, routine immunization, health system strengthening, and universal health coverage. He is also the co-author of a book titled Till We Win, India's Fight Against the COVID-19 Pandemic, which he has co-authored with Dr. Randeep Guleria, Director of AIMS, and Dr. Gagandeep Kang. And he has been considered as one of the credible voices of reason during this COVID-19 pandemic in India. So with this, I welcome Dr. Chandrakant Lahariya and all the other participants. Over to Dr. Chandrakant Lahariya.
Mr. Gupta, thank you very much for a kind introduction. The participant in this webinar, school principals, parents, it's really a privilege and honor to be here and speak about this topic, which actually had created a lot of panic among his parents and community in last 5 and 6 months, 5 and 6 weeks. And in the backdrop, if you hear some sound, that's my 10-month-old daughter. So please excuse me for that. I'm a father of a daughter, so I understand how much parents might have been concerned about this discourse and discussion around. So quickly diving into this area, around 2nd week of May, there was a discourse which started from somewhere unknown that there would be 3rd wave and children would be affected. Let me start with the answer to that question. There is no scientific or epidemiological evidence that in 3rd wave, which would happen in India, children would be affected. Children are unlikely to be disproportionately affected in 3rd or any subsequent wave. So please be assured that there is no reason to believe, I'm repeating these aspects, there is no reason to believe that any subsequent wave, be third, fourth, or fifth, children are at any increased risk. And there is a very solid science behind it. Many countries, including United States, United Kingdom, have witnessed more than 3 or 4 waves. And in none of those countries, children have been affected disproportionately in third or fourth wave. In fact, the good part is that children do get infected with the virus, but they do not develop severe disease. So children have always been getting infected throughout the period of pandemic, but they do not develop severe disease. And in this pandemic, all we are concerned is moderate to severe disease, which results in hospitalization. Mild illness is not a matter of concern, but even mild illness is very rare in children. So children are not affected by this virus, and that's a good part. How do we know that? So in all the countries across the world, data has been looked at of all the people or total cases of COVID-19. What proportion of infection occurs in children? So before I go into this number or proportion, we need to remember that in India, the proportion of the total population, which is constituted by children, is around 37 to 40%. Essentially, it means that if there are 100 people out of them, 37 to 40 are children younger than 18 years of age. However, if we look at the total number of cases in the mild, moderate, severe, which were confirmed in the country, around 8 to 11% are in the children. So while the proportion of population is around 40%, only 8 to 11 are among us children. So that's the number which we need to remember. So this is really low number. Remaining population 18 plus is around 60%, but around 90 to 92% of the total infection are in that population. So adults are more commonly affected rather than children. So adults are at a higher risk rather than children, and there is no reason to believe that children would be subsequently affected. Now coming to, okay. Now there is more evidence to it. So what Government of India did, Government of India analyzed the data from the first wave and the second wave of COVID-19, all the confirmed RT-PCR cases in the country. And they have compared that what is the age distribution of all the cases. And what government has found, and this was in the newspaper 2 days ago, that in all age groups, the proportion of cases reported between the first wave or second wave have always remained similar, which means there is no change in the proportion of cases which have occurred in children or adult or any age group. So in 0 to 10 years of the total cases, only 3.5% of the cases have been reported, while the population 0 to 10 years is around 22-23%. So 23% of the total population, but number of cases are 3% only. Similarly, in 11 to 20 years, the population is around 16% or so, but the proportion of cases in that age group is around 7 to 8%. So children have not been infected that much. So that's one part we need to remember. Children have not been infected in 2 waves, unlikely to be infected in the subsequent wave. Now, even this proportion, somebody can say that is a large proportion. But then key thing is that even when children are infected, they do not develop severe disease. There is a scientific rationale behind that severe disease. They do not develop severe disease. This particular virus, while infect us through the nose and mouth, so it's found in our throat or back of the nose, but to cause moderate to severe disease or even any kind of disease, it needs to reach our lungs. Now, to reach lungs, this virus needs to attach or latch to a particular type of receptors, which are called ACE, angiotensin converting enzyme 2 receptor, ACE2 receptors. Now, good part, and we are fortunate that these receptors are underdeveloped in children. So while children do get infection, they might have virus in their nose and throat, but children do not develop moderate to severe disease because the receptor is underdeveloped in them and they do not develop severe disease. I want to give you a more concrete example rather which caused some panic, the news about that caused some panic. You might have heard about the news that in Ahmednagar district in Maharashtra, around 9,600 children were infected in month of May. So that news made big headlines. Every channel was playing that news in the month of May. But what that news was, in a sense, misleading. It was misleading because in the same period, in month of May, in Ahmednagar, 86,000 of the total confirmed cases were reported in that district. So of the total cases, number of proportion of infection in children was around 11%. And now remember the figure, children constitute 37% to 40% of population. Overall cases were 11%. Now one can say, okay, 11% is fairly big number. Children are getting infected. There is no doubt about it, children are getting infected. But in the same month or same period of the 9,000 children who got infected, the 2 deaths were reported. Only 2 deaths were reported of the entire 9,000. We need to remember that the case fatality rate or mortality rate in the COVID-19 is around 1.3 to 1.5%. So if 9,000 cases occurs in adults, the expected or unfortunate number of deaths would be around 100 to 150 in that many infections. But on those children which were reported from Ahmednagar district, the number of deaths were only 2. So children are essentially like 1/80th or even less risk of severe disease and mortality, and that's the point. So children do get infected, but they do not develop severe disease. They are good part is that they do not die. The mortality rate is 0.0002%, so really low rate of mortality. Now we also need to remember that who are the children who get infected and then develop severe disease. So they are, if a child is healthy, there is a very little probability that child would develop moderate to severe disease. Only those children who have an underlying disease condition or previous illness are risk of developing moderate to severe disease. So we need to take care of those children who are undergoing treatment, who are who have any immunocompromised status or any other health condition, prior health condition, and they are at the higher risk of developing moderate to severe disease. But the infection is only different thing. Developing mild, moderate, and severe disease, the probability in children is very low. Now, I also want to share something which you might have read in last 2 days again. All India Institute of Medical Sciences have conducted a study in 5 parts of the country, including one area of South Delhi. And they collected blood sample and did a sero survey in that population. What they found that as part of sero survey, once sero survey conducted, the antibody are measured, and those antibodies are a proof of this thing, that whether that population or that individual has developed infection or not. So what that they found, the study found it, which was conducted by All India Institute of Medical Sciences, that around 73% of all the children whose samples were collected had antibody present, which essentially means the children had developed infection, but there were not that many cases. The infection in children is mostly asymptomatic. It does not cause moderate, mild, moderate, severe disease, and they are protected. So infection is very different thing, but developing mild, moderate, severe disease is very different. So children are already protected, already higher seroprevalence than the adults, and there is no reason to believe that this is going to be any different. So all the evidence, all the scientific evidence from all parts of the country say, and also from different parts of the world, indicate that children are at the same risk of infection, but the far lower risk of mild, moderate, severe disease. So risk of disease which requires hospitalization, treatment is really low. Infection itself does not mean if it does not result in the clinical condition or other health situation. We know why this is happening in the children. Now, coming to other part, why there are new variants and are emerging. Delta variant you are hearing, there was Alpha variant which was circulating earlier. You might have heard about Delta plus variant. Is there any reason to believe that new emerging variant could cause severe disease in children? The answer is no. These variants follow the same principle. They need to attach to a particular receptors, and then once they are attached to receptors, they can cause disease. Currently, there is no evidence that the ability of these newer variants to attach to a receptor has changed, and that's the reason that it's unlikely that even new variant would affect children disproportionately. If these variants have any property which is a higher transmissibility, which is equal to all age groups, but unlikely to affect disproportionately children. Now, I saw one of the questions which popped up that there were reports of more cases of COVID-19 in children in Brazil. I know that these reports had emerged from Brazil. However, you need to recall the same issue which we saw in Ahmednagar district and also in Maharashtra reports, that in Brazil, out of the total number of cases reported, which is very high, a total number of cases in children are 2,200 severe cases, which is a very small fraction and proportion of the cases. But this was reported in the media in a way that there is a disproportionate increase. This was noted recently, but there is no proportionate increase. Children do get disease. We need to remember one point. But their risk of getting disease is very low, very, very low. Like if adults have a particular ratio, the children has a 1/20th to 100th probability of getting severe disease. So children do get infected. Please remember that. A proportion of them might get a moderate to severe disease and may require hospitalization. But that proportion is really low. So in all settings, children get infected. They might get disease, but the proportion low. And this is the key point is this is unlikely to increase in any of the subsequent waves. So don't think that there is an increased probability or risk. So Brazil case was again misleadingly presented. There is another question which is coming on the screen, which points about that Singapore closed the school. Even that is another misleading report. If you go back to the internet and if you will search, what you would found that Singapore had very few cases in their country. Most of the cases, daily cases reported were single digit for much of the pandemic period. But somewhere around early May, they reported total number of 38 new cases. And most of their cases before those 38 cases reported countrywide in Singapore. Singapore is a small country. Most of the cases before those 38 cases were coming from dormitories. Dormitories are usually places where the migrant workers live and work. But within the local Singapore resident, the number of cases were really small. So when one particular short period, Singapore reported 38 cases, which was for them a really big number. Of those 38 cases, they had 4 cases of children. And on that ground, because for the first time they reported outside that area because of some exposure of those 4 cases, so they temporarily closed the schools. But that was not the reason that it should be considered that there was a drastic increase. There is a possibility of infection, and 4 cases out of 38 cases in a Singaporean system, they consider really high number, but that was not the rise, and that their closure of school and their approach to adopt a public health measure is very different, and that's why they closed the school. So even Singapore case study is not correct, and it was misleadingly presented in newspapers in India. So those are some of the broader principles. Now, all the experts and even leading pediatricians and our particular task force has reviewed all the available evidence. Let's go back to some key principles and let's remember these points. Entire population, all age groups are at risk of getting infection. So infection happens all across age groups. The sero surveys have found that from the very beginning of the pandemic, children have been getting infected, which they have developed antibodies in a very similar proportion to antibodies in adult population. But what we see that adults, especially those with comorbidities and elderly who get moderate to severe disease. Our purpose is to prevent moderate to severe disease. So all age groups get infected. They are getting infected from the very beginning. Second part, our concern is the moderate to severe illness. Only adults and elderly are at higher risk. And even within adults, the adults with comorbidity and elderly are at higher risk of developing severe disease. Children are at very, very low risk of severe disease. There are some analyses which have said that children who are 0 to 10 years when we compare this age group with the age group of 80 plus, that 80 plus age group is 5,000 times higher risk of severe disease and mortality than children. So that's a kind of difference between the mortality and severity of disease. So children do not get. Third part is that all those reports were misleading. Another example. Some of you might have seen that Maharashtra, there was another report which said that Maharashtra reported 97,000 infection in children 0 to 18 years over a period of time. But what was forgotten, that during the same period, Maharashtra reported 29 lakh cases of COVID-19. So essentially, for 37% of the population, they had 3.5% of the cases in that age group. So its probability is really low. Every evidence, no matter which way we look at, children are not at higher risk. There is no probability that children would be at higher risk because there is no change in the virus, no scientific mechanism by which virus works, it has changed. Final part on this, and then I'll touch some other aspect. Some people have argued that since adults have already developed infection, or elderly have also already developed infection, and now they are getting vaccinated, so the risk is that children are the only age group which is not getting vaccinated. So children would develop severe or moderate to severe disease, or would be higher number of cases in subsequent wave. What we need to remember, that first thing is that this idea of third wave, especially affecting children, is completely wrong. We know that Delhi state or city of Delhi has already witnessed 4 waves. So while national level it was second wave, but Delhi it was 4th wave. So it's not linked to third or 4th wave. It's like there is no change in the virus, so there is no change in the risk to children. Now coming to adults getting vaccinated, will it pose additional risk to children? Answer is no. Because children are already infected and developed antibody, that's one part. But there is more epidemiological answer from United States of America. The answer is that there is a study and data available that US started vaccinating around mid of December 2020. And since then, by early June, United States had covered around 70 to 80% of adult population with at least 1 dose of vaccine. And during that period, they have analyzed the data that how the COVID-19 infection and severe hospitalization had changed over a period of time from start of the vaccination till early June. And they have found that there is no change. Even with the increasing vaccination coverage in the adult population, there is no change in the moderate to severe illness in children at all. It has even same. So what US is at the beginning of early June, India is likely to be in that situation of higher vaccination coverage by November and December. And if this had not happened in US, it will not happen in India. It's the same epidemiological principle. Virus is more or less same. Questions are appearing on the screen that Delta variant and newer mutations, will they affect children more? No, because principle is same. The virus works through attachment to a particular receptor, and that has not changed. So it's only those individuals who are at high risk for the current strain are likely to be affected with the newer strain. The pattern of infection is very similar. Children are not additional risk. The receptors are not there. I'm saying this repeatedly. Other questions are appearing, but before I move to the next part of where I would like to talk about vaccines and then opening of schools and then also a bit about masks. So before going to the next part, there are another set of reports which are appearing in media, and those reports are about multi-system inflammatory syndrome of children. Like this MISC is also another concern. Like it's so widely being reported in media that it appears that it's causing many such cases in the children. We need to remember that this is not a new syndrome. This is not a new disease. It was always been there. It has always been there. And it's simply that somehow in a particular way to make a human story of these situations, even though these conditions happened in the past, these are being reported in the media and creating some sort of panic. There is no evidence that even those cases have increased. What we need to remember that children with the pre-existing health condition are at a slightly higher risk. This higher risk is far lower than adults, but definitely within the age group of children, if any child has a health condition, was hospitalized in recent period for any other health condition, those children are at higher risk of developing moderate to severe COVID-19 disease, and we need to take care. MIS-C and other conditions always existed. They are being reported, especially in Hindi media, Hindi newspapers and Hindi news channels, but also in English, and that's unfortunate part. Good, it's generating awareness, but it is also causing panic, but it's not linked to COVID-19. The mutations, I have repeatedly said that is not linked to the, they will cause any special challenge for the children. Coming to the vaccines quickly, because I'm mindful of the time also. So coming to the vaccines, currently the vaccines are licensed for age group 18 years or older in India. There are 3 vaccines now: Covishield, Covaxin, and Sputnik, which will also be started from tomorrow onward. For children, currently no vaccine is licensed in the country, in India. But in other parts of the world, United States, Canada, and some other countries in Europe, the vaccines have been licensed for 12 to 17 years of age group also, and vaccination is started. In India, a few vaccines are being undergoing clinical trial in children, especially Covaxin is undergoing clinical trial for age group of 2 years to 17 years. However, those clinical trials, one thing what we need to remember, that the vaccine is same which is administered to the adults. It's just that they look at the immunogenicity, because no vaccine is licensed unless the trials are done in that particular age group. And that is the reason that this vaccine is being undergoing clinical trial. And once those clinical trial findings are available, usually those clinical trials are not the full clinical trial as done for the original vaccines or the original clinical trials. There are smaller trials on around 500 to 600 children. They look at immunogenicity, they look at safety of the vaccine in this age group. What we need to remember that children are a little more active immune response, have an active immune response, so they give a little higher reaction. So in such kind of clinical trials, mostly it is checked whether the same dose is required as for adults or a reduced dose is required. They also look for the adverse events in those children. So those clinical trials are going on. We can expect that the findings or the results of that study would be available. Those clinical trials would be available by early September or sometimes around that. So then only the vaccine will be considered for licensing. So vaccine for children in India is unlikely to be available before mid-September or late September. That's one part. The product principles of vaccination remain the same. It's all likelihood these vaccines would be found safe and effective because they work on the same principle. As I said, dosing will be the only challenge. But I also want to flag, and some of the questions which are appearing on the screen are linked to that, the purpose of vaccination in India till now is preventing moderate to severe disease. That's why it's always the prioritization is done for health workers who are at higher risk, then elderly population who are at higher risk for developing moderate to severe disease, then adults with comorbid conditions. Then the next priority comes the 18 to 44 years. Children are then the last priority for vaccination because the risk to the children of moderate to severe disease is lower. That's why they are in the last priority, and that's one reason. But other reason is that vaccine has not been tested or undergone clinical trials. But as some of you are asking here on the screen, I see that since children are the relatively lower risk, then they do we need vaccines for them? The answer is yes, we need vaccines for them, but since vaccines are in finite supply, they should be prioritized initially for the reducing morbidity and mortality with the disease. The purpose of vaccination in children is going to be very different. And that purpose is reducing the transmission in the community, because even though children do not develop severe disease, but since children carry the virus in their nose and throat, and then they can pass on the virus to other children and other members of the family who are unvaccinated. And that is why the children need to be protected once vaccines are available. to reduce the transmission of disease. Now, there is another dimension to it. So the immediate priority is vaccinating adult population, because the purpose of adult vaccination, reducing morbidity and mortality. These vaccines are known to have a limited effect, not sufficient protective effect on reducing transmission. So person who get vaccination is protected himself, which essentially means that person, he or she can will not develop moderate to severe disease, but the person can still have a virus in their nose and throat. Person can still get infection, but they would not develop disease. So that's why the individual who is vaccinated need to keep wearing mask to protect others, because he might have virus and pass on to others. Now with the children, what we want to do, probably those vaccines, there could be an alternative vaccine. The better vaccines or other vaccines might be explored and might be available. Preferred vaccines could be something like a nasal vaccine. You might have heard Prime Minister talked about that there are research going on nasal vaccine. So for more suitable vaccine for children are likely to be those which prevent children from disease, but also help reducing transmission. So a nasal vaccine is something which will be easy for administration and also can reduce the transmission. And currently there are not that many nasal vaccines. So it's worthwhile to wait to vaccinate children with the right kind of vaccines and protect them, but protect other family members. So there should not be any hurry or rush to vaccinate children in any part of the world. We also need to remember another part, that the pattern of infection and moderate to severe disease in children is very U-shaped. When we say U-shaped, which essentially means the children who are like younger than 2 to 3 years are more likely to develop moderate to severe disease than somebody who is 3 years to around 10, 11, 12 years it's the lowest risk. They are like a very, very, very low risk. Somebody who is healthy 3 years to 11 or 12 years, nearly no risk. And then again, once age start increasing, 12, 13, adolescent age group, essentially, the risk of moderate to severe disease increase. So the first priority of vaccinating of that age group, which is a higher risk of moderate to severe disease, and that's why adolescents are being vaccinated. But we also need to remember that even when vaccines will be licensed, those vaccines will be in the limited supply. And India has around 50 crore of 18 years or younger population. Essentially, each one of them require 2 doses, so 100 crores. So it will be a long time before this population group can be vaccinated. So we need to keep expectations real. This population group need to be vaccinated because we, at the end of it, want to reduce the transmission of virus, and that's how the pandemic will be fought. But this is not an urgency. There is a benefit of vaccinating children. So one of the questions which appeared on the screen is whether it is useful, since children do not develop severe disease, whether children need to be vaccinated. Answer is yes, children need to be vaccinated, but the risk of their developing disease is low, but benefit of vaccination is far bigger. And that's why they need to be vaccinated. Vaccination of children will protect them, but also reduce the transmission of disease in the setting and will help the community or society coming out of the pandemic. Now, moving to the next part, that when do we expect schools to be open? This will be a little challenging decision based upon different factors. What experts are discussing that at least in this academic year or coming academic year also, it is unlikely that schools will be full-fledged open in a full scale. However, once vaccination coverage reaches and once vaccination of children started, it might be given a consideration, but it is not expected that before early 2022, schools can be open for children. We know that virus is airborne, so there is a need and likelihood that some of the modifications need to be done to ensure proper ventilation in the classrooms before children can be invited. We know that Indian classrooms, especially in the government, but also in other setups, are either the ventilation of the classrooms is not really proper. Even air conditioning, it could be a challenge, but how to better develop those systems, how to increase spacing within the classroom, those would be the consideration. And also the circulation of virus in the community and the vaccination coverage achieved in general for wider population, those will be the consideration. And of course, because it's not about merely classrooms also, but open space within the schools and interaction between children in the school, and all of those need to be considered. So what we know now that this would be a very graded, considered decision, of course, guided by the vaccination coverage in various age groups. But like it cannot be answered a priori now. What we broadly know that until the end of this year, we should not expect that there would be any scope of opening the school. Coming to the other part, which is linked to this overall theme, but also opening of the school, we and everybody talking about there would be third national wave, which can happen anytime. Like some of you might have heard AIMS director saying in a TV interview this morning that the third wave could happen in 4 to 8 weeks also. But broadly, many other experts are saying that it could happen somewhere around November 2021 or a little later. Let's understand why these waves happen. So the key concept is that whenever there are cases which have declined, and then whenever those cases go upward, that is called wave. So wave is not linked to the extent of the wave. Like it needs next wave does not mean the cases would go 100,000 or 120,000 per day, more than 120,000 per day, then only it will be called wave. So whenever there are particular baseline which has been achieved, if there is an upward trend in those numbers, it will be called wave. And as long as there are susceptible population, essentially the population which does not have antibody, or in other words, which has either not developed natural infection or not received vaccination, as long as there is that kind of population, there is a risk of that population transmitting to each other, and there is sudden spike in the cases. And it is also dependent upon the new strains or variants which emerge. If they are more transmissible, as an example, the second wave in India happened due to Delta variant. Now, this Delta variant is 50 to 70% more transmissible than the Alpha variant, which was circulating earlier. The Alpha variant, which came from which was first reported in United Kingdom. So it depends upon that what would be the extent of wave and when that would happen in many factors: behavior of the people, circulating strains, emerging strains, and the susceptible population. If vaccination could be ramped up quickly in all settings, then the scope or the scale of wave would be smaller. But it is true that there would be a next wave. It could be what we don't know when, and what we don't know what will be the scale of that wave. But as long as virus is circulating, as long as population immunity is not achieved to 80 to 85% of population, either through vaccination or natural infection, it will be a next wave. I did not see that. Yeah. So the final part, I'm coming another 2 minutes and then I'll close. So the final part is that one of the key questions which people ask is about the mask. Who should wear a mask?
Yes.
So the answer is that anybody, the World Health Organization recommend, and even Government of India recommend that anybody who is older than 5 years should wear mask, preferably double mask when going to crowded places. And the masks are not recommended by anybody, any agency or institute for children younger than 2 years of age. The reason is that they require far more oxygen, and their oxygen requirement is far high. And some of the professional associations recommend that masks should be worn by children of 2 years to 5 years. But broad consensus is, global consensus is that anybody who is younger than 5 years need not to wear masks. Also, anybody who cannot take care of himself, herself, or need to be provided care should not be made to wear masks. It should be guided. So especially young children need not to wear masks. They are going outside. Of course, face shield or a simple plain cloth cover can be used, but young children younger than 2 years do not require any such cover. They have a very low risk of developing disease, and the oxygen requirement is far high. Masks are not recommended. I think I'll stop here, and if there are questions, I'll answer those questions. Thank you very much.
Thank you, Dr. Lahariya. There are a few questions which are there. People are asking if the schools are started in staggered manner. Should the children be allowed to go And what is the impact of vaccination on that? And is flu vaccine, with flu vaccine will suffice with the, because the other vaccination is not available for young kids?
So
Three questions.
answer to the first question is that the schools will, as and when they will be open, will always be open in staggered manner. But that is going to be a very considered decision depending upon local situation. I believe that each and every state and each and every setup would be informed about the broader principles of how to open the schools. Like it is going to be very different for public sector and private sector schools, depending upon the infrastructure and the requirement. But I think that decision will be taken by various recommendatory bodies over a period of time. I don't foresee, and that's what experts don't foresee, that another few months, like at least the entire rest of this year, there is any probability of schools being open. The probability of opening school is very low, or physical attendance at school is low. Early next year, it will be staggered or a very considered decision that what proportion of children are invited, whether one particular class is invited one day and another class is invited next day, and also what modification should be done in ventilation, etc. Coming to the second part, the role of vaccination is more so for an individual level. When vaccination coverage is really low, like 15% in that particular age group or 20%, it provides more of a individual benefit. It is only when the vaccination coverage crosses 50% or 60% that then it provides a group benefit. So vaccination of adult population, which is currently happening, will increase and definitely reduce the transmission of virus. I believe that there would be more studies which will be required in the children, because children already have developed a sufficient amount of antibody. And there is a question that which age group should be prioritized for children, what should be approached for children. As I already highlighted, whether the same vaccines which are being offered to adult, injectable vaccine, should be given to all children, or only adolescent will be given the injectable vaccine because they have a different kind of risk profile of moderate to severe disease, or children could be given a nasal vaccine which will be easy to administer, will reduce the risk of transmission. So there will be many unknown and other consideration. For example, if a nasal vaccine is not available, should children still be given injectable vaccine in spite of low risk? The broader answer is that though risk is low, but still a risk, there is a risk to the children, and in the broader benefit, they should be vaccinated. Third part is about flu vaccine. What we need to remember that flu vaccine has its own benefit. But we also need to know that most of those flu vaccines which are developed those vaccines are developed on the annual strains which are identified to be circulated in European settings. So those vaccines are mostly developed for European strains which are circulating, which are identified prior to that flu season. Now, the flu season in European setting is around November, December, and January. But flu season in India is a rainy season, July to September. So those vaccines are actually not really developed for Indian setting. However, they would provide some benefit against flu. But in my opinion, they do not provide any direct benefit for COVID-19. It's just that obviously children are at risk of those kind of common cold conditions of flu. So they will reduce one type of illness, and that will help in boosting immunity, but no benefit on COVID-19 vaccination has been scientifically found of. No benefit on COVID-19 disease has been found of flu vaccine. So as a parent, somebody want to get their child vaccinated with flu vaccine, remember it will benefit, it will provide protection from flu, not from COVID.
Okay. And what about children? Can they be allowed to walk in the park or play in the park?
So I think that's the one policy which government has not done correctly, in my opinion. So outdoor spaces are really safe for a majority of the population, like for everyone, because there's a really good ventilation in the outdoor spaces. But government in some parts of the country have not opened the public parks. They are still closed. But once public parks are open, I think in a closed environment, family members can go in the outdoor spaces and parks, etc., and play there. But it's recommended to wear masks even in the public spaces or maintain distance and not intermingle with other people. But yes, open spaces, outdoor spaces are far safer than the indoor space or closed space or crowded space. So parks are safer, and of course, I believe that by next week, government would take decision and it will be open for general public to go to parks.
Ms. Manisha wanted to know that Covaxin is not approved in many countries. So is it okay for children?
No, and also no vaccine is licensed for children in India. It's undergoing clinical trials. So only when the clinical trials are completed, it will be approved. Currently, it cannot be administered or given to children in the country. As far as approval of vaccines is concerned, it is a different process. So we know that any country needs to complete, any manufacturer need to complete the clinical trials, and then only the vaccine is licensed in those settings. So though India gave a emergency use licensing on a clinical trial mode for Covaxin, but the Covaxin phase 3 clinical data has become available a few weeks ago, a month ago only, and it has not been published in a peer-reviewed journal. So every country follow their own approval process, including the vaccine has not received the WHO authorization because of the same reason. The data was not available. Once the data will be available, it will be approved. So it's not a concern. It is a safe and effective vaccine. Some of the people raise question that these vaccines have been developed hurriedly. That's not correct. The vaccines have followed all the due processes. The clinical trial have adopted every single step. It's simply that the processes were the red tape within those processes were avoided, and whichever steps in approval process could have been avoided but simplified. But otherwise, the clinical process has been followed throughout the research process. What we need to remember that the safety of vaccine is paramount, and in all stages of clinical trial, phase 1, phase 2, phase 3, safety of the vaccine is considered. So this vaccine is safe, effective, and it's approved in India. In other countries, it has not been approved for different reasons.
Great. I hope that answers the question. Ms. Leena wanted to know that how frequent the vaccine shots be taken in the coming years.
That we don't know as of now. So there are some of the unknowns there. But what we know that at present, individual need to take 2 shots of currently licensed vaccine at the recommended interval. The recommended interval is 4 to 6 weeks for Covaxin, 12 to 16 weeks currently for Covishield, and Sputnik V is given at the interval of 3 weeks to 13 weeks. So those are the current recommendation, but beyond that, there is no consideration that when a booster shot will be required. Broadly understanding principles of immunology and vaccinology, since Covaxin is an inactivated or killed vaccine, it may require a booster shot, which could be 9 months after the completion of first primary immunization schedule or a year after. But our understanding about that booster schedule will be developed over a period of time. It's difficult to say at this stage. But all of these vaccines might require a booster shot, maybe a year later or a little later, but we don't know answer yet. Just remember that once you take these completed immunization schedule, you are protected at least for 6 to 9 months. And by then you will complete that period, we would have a better answer or more scientific understanding.
There is another question which says that if you have antibodies, then should we go in for vaccine?
The answer is that current approach, it is not recommended to get antibody test done, antibodies tested before you go for vaccination. Forget about antibody. When we talk about somebody who has developed natural infection or mild, moderate, severe illness, so that person would definitely develop antibody. But even for the individual who have recovered from COVID-19, current recommendation is to go for COVID vaccination 3 months after the recovery. So even those who have recovered are recommended to get vaccination as of now. So I would not recommend getting antibody test done, because getting antibody test done is far more expensive. And we don't know the benefit of this thing, but vaccines have a clearly proven benefit beyond antibody, because vaccination results in development of antibody, but also T cells, and which may last longer. So my suggestion would be that the current knowledge indicate that get vaccination. Do not focus on getting your antibody test either before or after vaccination. So much so that even after vaccination, some people want to get tested for antibody. But yes, please don't get tested for antibody. It doesn't make a difference whether you develop antibody or do not develop antibody. It's not going to change the course. You might have those T cells which might provide the protection.
Dr. One of our viewers want to know that if a mask is sufficient for wearing in crowded places, but since this is like an airborne disease, so can it enter through eyes?
Usually, it's not through eyes. It need to reach your lungs, and to reach lungs, it had to go through the nose and mouth. So there is no evidence of it getting an individual getting affected through eyes or cornea. So only nose and mouth are the route to the virus to the lungs. But we also need to remember, it's not the quantum of virus only. Like virus need to go to your nose and mouth, back on nasopharynx, the back of the nose and mouth. It need to multiply, become a sufficient quantity there. Then it need to enter lungs, and then only individual gets sick. So there is a multiple stops. There are multiple steps involved. So unlikely, only nose and mouth are the route, and that's why it's important to wear the mask correctly, not through the eye.
Okay. So for children, is the cloth mask acceptable?
Cloth mask is acceptable for the cloth mask is fine. There are studies which show that the protection by the cloth mask is relatively lower, around 65 to 70% protection. But in the current setting, with the virus being airborne, it is recommended to wear two masks. One could be surgical mask, the blue mask or blue mask, which are available in market inside, and then a cloth mask outside for everyone, and that provides as good a protection as N95 mask. I would not recommend wearing N95 mask by anybody in general public. For children, a single mask could work because they do not easily get, their immune system works better. But if they can wear two masks, it's better. But at least one